Good afternoon, everybody. Welcome to another episode of EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue, and today I am joined by Shannon Van Meer, and we're going to talk about an interesting case that she had with a febrile seizure. Thank you and welcome.
Thank you. Thank you for having me.
All right, so let me set the stage. So we had Rescue 14 and Engine 14, and you all were dispatched to a drugstore parking lot, and the call was for a 31 Delta to an unconscious 1-year-old.
Yes.
Always high acuity, always high alert. What are you thinking when you're on the way to this call?
So initially, the dispatch was a 31 Delta, and then as soon as we went en route, it updated to actually a possible 9 Echo. And we were actually rolling with a County Engine 33, and I immediately asked if our engine was available because I knew they were going to be closer. It was our people if we needed somebody to drive us into the hospital, all those things. Obviously, hearing that it's a potential 9 Echo kind of ramps everything up. On the way to the call, my driver and I pull up a protocol and try to kind of pre-plan, like assign roles, go over drug dosages, sort of have a plan for when we get there. If it's a 9 Echo, it's kind of a different story, but the 31 Delta, we were thinking of possible reasons for why this kiddo would be unconscious and unresponsive. Absolutely.
That's a great job of thinking through all those steps before you arrive. Okay, so you've thought through all those possible scenarios. You got our engine running along with you. You get to the scene, and what do you see?
So we were told by the mom and the mom's friend the patient was in her car seat and that she kind of was staring off to the right side and became kind of fixed and stopped breathing. So the friend pulled over into the parking lot, took the patient out of her car seat, and started doing CPR and rescue breaths. When we got on scene, luckily the baby was awake and conscious and breathing, good color, not crying, looked a little, wasn't limp, but definitely looked a little kind of post-ictal almost.
Okay. And great work by Alarm Room to give those pre-arrival instructions because they can only go off the information that they get, but that's great because it helps you change gears when you get there and kind of rethink and slow things down. So talking through your initial assessment, when things start to settle, you realize it's not a cardiac arrest. What do you see when you're assessing the patient?
Correct. So we realized it wasn't a cardiac arrest, but kiddo still looked sick. We immediately got her in the back of our rescue just so that she wasn't in a parking lot and we could better assess her, see her. She was wearing a onesie. She was in mom's arms, still wasn't crying, but you could tell she wasn't quite acting like a normal 1-year-old would. So we kind of opened up her onesie to expose her chest, see if there was any trauma, especially knowing that somebody had potentially been doing compressions on her too, wanted to kind of assess her chest and see if there was any kind of signs of trauma there. Immediately kind of noticed that she was belly breathing, so it had some accessory muscle use, so kind of struggling to breathe. So we put her on some blow-by oxygen while we ended up getting a baseline set of vitals.
Okay. Talk us through those vitals. What did you see after that assessment based on your?
So after the blow-by oxygen, we had just started it, but her room air sat was 89%, which is not, I mean, it's lower than I'd like, but we gave her the oxygen more based upon her accessory muscle use and kind of just how she was presenting. Her heart rate was 166, respiratory rate was 22. And then just also doing a physical exam, we noticed that she felt really warm. So we checked a temperature and her fever, she had a fever of 105.
Oh, wow.
And that was on our thermometers, which I feel like traditionally run a little lower than like 5.5s or even ones at home. So
absolutely,
she was pretty hot to the touch. And then we did check a blood sugar as well, and it was 103.
Awesome. Great job of catching all that. So obviously looking at the whole picture, exposing the patient, looking at the work of breathing. So you're not basing it strictly off of the O2 sat. You're looking at any accessory muscle use. So that's a fantastic job. Automatically, you know that there's a high temperature and you check the blood sugar, which are all key points. Did mom elicit any history?
Yeah, so mom said that she had been, I think, diagnosed with RSV, I believe like a week or two ago, that she had been to the hospital and that she had been discharged, and the patient was administered Tylenol previously in the day. And the mom stated that she had been at a friend's house. I believe it was Super Bowl Sunday. So she was at a friend's house at a Super Bowl party and then noticed that the patient was kind of acting sick and lethargic, and then decided that she needed to take the patient home in order to administer more Tylenol, because the last time she had it was earlier in the day, and this was at night. So she definitely was due for another dose of Tylenol for sure.
Okay. So led you down the path of a febrile seizure that was likely caused due to a viral illness. And then what was your plan as far as administering Tylenol? What was going through your mind?
So definitely when I noticed her work of breathing and then also the very high fever, we did have a 5.5 on the way. We let them know that it was not, in fact, a 9 echo, just to kind of slow everything down a little bit, because everyone's mind is working a million miles an hour, and that's kind of what you think you're walking into. And so knowing that, she had a high fever, we knew that we were going to administer some Tylenol, 15 milligrams per kilogram. So definitely asked mom if she knew the weight of the baby, putting it in. And obviously most people know pounds, but MDT will convert it to kilograms for you. And then we definitely pulled up our pediatric formulary so that we knew exactly what dose to give her for Tylenol. And then also having a high suspicion of it maybe being a febrile seizure, just in the back of my mind, also making sure that we knew our benzo dose for that patient based on her weight.
Okay. We'll get to the Tylenol here shortly, but when you talked about your benzos, if you're going through that step in your mind, what benzo were you going to choose, and talk us through what you were planning on giving that patient if they were to start seizing again?
So I would have given her Versed, because that's what we carry. And definitely just, we have our Broslo tape. In 14s, we have a pediatric bag, and it has the Certidose, and it has all of our Broslo tape and all of that. So just talking it through with everybody else and making sure that we knew that we had that drug, and knowing our dose and our amount, and just having that in the back of my mind, and how we would have administered it and all that, just in case she happened to seize again. She wasn't looking like that was going to happen, but it's always good to be prepared and know your dose and be prepared for it in case it does happen.
We talk about routes with the Versed, and I know it's always difficult. It's a challenge with IVs on kiddos. Talk us through your thought process on that and how you would encounter that, or if you would just look for another route.
I think that if, obviously, if she's kind of having an active seizure in front of you, if you have an IV ahead of time, that's a great route. But if you don't, you can always give it intranasally, or also I think it's a nice quick route. And then that way you don't have to try to work on getting an IV on a kiddo that's seizing. It's hard enough to get IVs on kiddos that are just sitting still. So those are the routes that I would most likely go if she was actively having a seizure in front of us.
Absolutely. I agree. And we talk about the lot in credentialing, and we talk about the preference being IM, the 0.1 milligram per kilogram, as opposed to even the IN at 0.3 milligrams per kilogram. Specifically, the intranasal being difficult when they're dealing with some sort of viral illness. There's usually a lot of junk in the nose.
They're congested.
Exactly. Yeah. So yeah, great thoughts. We talked briefly before we started on some issues we encountered with the Tylenol and its current packaging. Talk us through what you encountered and how we can work to fix that.
So I don't know, anybody that has kiddos at home know that the Tylenol comes and there's a little tiny hole in the top. And if you get it from the drugstore, if you have a kiddo at home, there's a syringe that you can fit into that little hole, and then you invert it and draw up the amount. The syringes that we have on the truck don't fit that. So it usually comes with a cup. It's, at home you can rinse it out and put it back, in your cabinet. But when you're on the truck, you don't really have that option. So unless it's a brand new bottle that you just open up, you may or may not have that cup. It was a brand new bottle for us, so we were able to open it up, squirt some into the cup, and then draw it up with a 5cc syringe. But again, you might encounter some Tylenol that's already been opened and you don't have that cup. So you just kind of try to find some sort of receptacle to put it into in order to draw it up if you don't have a syringe that will fit in the top of this.
Yes, absolutely. And I appreciate you all bringing that up to us today, because we had encountered it recently. So we reached out to a vendor who's now going to be able to provide the 5cc syringes that have the ability to draw out of that bottle. So that'll hopefully help so we don't encounter those issues. As we know, those cups get lost pretty easily. So I appreciate you bringing that to our attention. So talking through finally on, you mentioned in the review of the chart of this specific call that you exposed the patient. We talked about looking at the work of breathing. You talked about no signs of trauma. What were you looking for, or what were you removing from your thought process when you talked about trauma?
I think we always, especially with kiddos at that age, unfortunately, have to have a high index of suspicion of potential trauma, shaken baby, child abuse, neglect, just to make sure that we check that box and make sure that that's not what's going on. I think it was pretty obvious with her that she had an illness, respiratory in nature, that caused this, but you still got to go through and check that off to make sure that that's not what's going on, just because you have to have a high index of suspicion, because most 1-year-olds aren't unconscious or unresponsive and need CPR without some underlying cause. Obviously, they're healthy little humans.
Right, so. Absolutely. And that's a great point. And I appreciate you bringing that up and checking for that, because the presentations are so similar to even febrile seizures. We might see an increased temperature, right, in the same presentation in a patient who did experience abuse. So I appreciate you bringing that up, documenting it in your chart and talking about it a little bit today. And one of the other things we have talked about within the division is the increased access to fentanyl that some of the children are encountering, whether that be by accidentally eating a pill or just coming into contact with fentanyl. We're seeing more circumstances where kids are found unresponsive for unknown reasons. And outside of situations like this, knowing that if that is a potential option, or even if it's not as a rule out, if there's no other reasons, then we should be administering that Narcan. So Absolutely. That's a great thought process. Well, it's great. And as far as the turnover from the patient you were able to treat, you got him on some oxygen. Did you see improvements in the patients during your time with them?
Absolutely. And that's kind of another reason why I sort of, her high fever kind of being a little postictal, and after the oxygen administration, she still wasn't crying, but she was definitely, her color improved. She was more responsive to mom. All of those things kind of raised that suspicion that it potentially had been a febrile seizure, and she was maybe a little postictal. So with the oxygen, the accessory muscle use and the belly breathing improved, her color improved, and just in general, her ability to track and sort of be more aware and conscious all improved with the oxygen.
Outstanding.
Yeah.
Great work once again by Engine 14, Rescue 14 on a stressful call, but one that we really can make a difference and an impact in the treatment that we choose. So I thank you again for the work that you're doing every day. And thank you for coming to share the story with us this afternoon.
Absolutely. My pleasure.
All right.
Thank you.
That's it for today's episode of the EMS case studies. If you have any interesting cases, feel free to enter those in SharePoint. If there's any questions, always feel free to reach out to your quality assurance officer or the EMS division. Thank you.